We shall now hear evidence from the Academy of Medical Royal Colleges and the Institute of General Practice Management. Once again, I'm afraid we have to stick to the timings, and this session will end at 10:55. Could the witnesses briefly, from left to right, introduce themselves for the record?
Good morning, I'm Kay Keane. I'm a full-time practice manager at Urban Village Medical Practice in Manchester, and I'm the chair of the Institute of General Practice Management.
Hello, I'm Jeanette Dixon. I'm the current chair of the Academy of Medical Royal Colleges, a past president of the Royal College of Radiologists and a practicing consultant clinical oncologist. Thank you very much indeed.
Dr. Johnson.
Thank you, and I perhaps should reiterate I'm a member of the Royal College of Paediatrics and Child Health. Dr. Dixon, NHS England has responsibility for workforce and workforce planning. How do you think the bill will affect this, and what effect is the delayed workforce plan having on the ability to plan a workforce for now and the future?
I think I would go back to some of the comments that have been made before. It's the opportunity cost sitting at the moment. We know the workforce plan is being worked on in the background, but when you're unsure of what the operating and delivery model will formally look like, there is a difficulty in seeing what the workforce will be for that. But also we're talking about massive changes in the way we think about care delivery, and we think about movement into the community, we think about a different way of working. So we do need a different workforce, and therefore we need to put in some work to look at how curricula drive a different type of workforce, how we train people to work in a different way, and how we empower them to see those opportunities to work in that way when they don't have actual role models. So there's a bit about, we need a culture shift anyway, whatever's happening, but the abolition of NHS England in many ways is increasing the time. It's that the opportunity cost of things need to move, and they are moving, but they're not necessarily moving as fast as they should do.
So in essence, the fact that NHS England's being abolished, whether that's the right thing or wrong thing to do, is going to have an effect on the delivery of new services.
Dr. Dixon?
I think it has effect on... We are delivering service as normal, but that headspace and the innovation to see what the future should be and work towards that future actively is limited by knowing what that future looks like.
Thank you.
Kay Keane, do you want to add to that at all?
Just really on the kind of left shift that we keep hearing about, and we don't know what that looks like. We don't know what that is for practices. In general practice, we're very practical. We will get on with what's in front of us. So the actual big organisational changes don't have a huge effect on the day-to-day seeing of patients and organising that, but understanding what's around us does.
Thank you. Thank you. I wanted to move on to Kay to ask you about the single patient record, and whether you feel that general practice has had enough information about their role in terms of who's responsible, who's accountable, who will be editing, who'll be responsible for checking the editors are right on this single patient record.
Dr. Dixon?
I think the legislation is very much an enabler for a single patient record. The devil in the detail there is not entirely true. If you ask most patients, in my experience, would they like a single patient record, they feel it's already there. They don't understand we don't have that ability to share their data in a way that works for them. And therefore I think the idea of a single patient record is very much a lodestone for medical practitioners and most patients when you talk them through it. The detail of how you achieve that and how you go about it and who owns the data is a much more tricky issue for many, including the professionals but also the public.
Ms. Keane?
I would agree that the detail isn't there at all. At the moment, we kind of look after that data that's in the GP summary care record. That creates lots of questions for our patients. They'll see information in there that they're not sure about, that they want help with. They'll perhaps be able to read some of their hospital letters within that. But there are lots of patients who have a variety of health inequalities that might mean they can't access that data. So our non-clinical staff in general practice are often helping them to navigate their way around all of that information. We also have patients that will read something in there that they want clarity on, maybe something that's happened a long, long time ago that they can't remember and they want explaining to them. So all of those things take time, and it's where the responsibility for that will go. That does take an awful lot of resources in general practice, to educate the patients, to support the patients, to help them navigate their appointments being on there, their letters coming through in that way. So it's where that responsibility would sit. At the moment, that of course sits with the GPs, but practically it's practice managers up and down the country that take on that day-to-day responsibility.
Just a small question, if I may, Chair. When we've, Dr. Dixon, we've all looked after patients who have, even in paediatrics, we've looked after patients who have ring binder after ring binder after ring binder of notes. And clearly, when seeing a patient for 20 or 30 minutes in clinic, there is not time to read ring binders of notes. So, to what extent will the single patient record provide an obligation to clinicians to have read and understood everything with every appointment? And is that really practical?
Dr. Dixon?
I think you need to have a belief that you have found out enough about a patient to deliver their health care. I would turn it around and say it is very, very difficult to deliver appropriate care to somebody who you do not have full information on.
Yeah. Yeah. The question is, how do you find it within the way it's structured? Yeah. Thank you.
Is that another question?
No, thank you, sir.
Thank you. Minister.
Well, if I can pick up that, Sir Roger, for Dr. Dixon, can you describe how you think single patient record could be transformative for patient care, given where we are?
Part of it's been touched on for patient experience in the previous speakers. Patients come in, they give their same story again and again and again to different healthcare professionals in different settings. That frustrates them. Patients are human. I forget what I did last week. Patients forget what they did last week, let alone 10 or 20 years ago, which is still relevant increasingly. I think there's a bit about if you travel, if you go on holiday, you go to Whitby, you fall over, you break something, you have tests done, you come back to your house somewhere, central London, you can't see that information, you cannot share that information. So there's a danger in there's the opportunity of being able to see everything for a patient across primary care, secondary care, social care is a huge benefit to patients in terms of their view of a seamless care, but also in terms of in safety. So I have a chronic health condition, part of my care is delivered by general practice, part of my care is delivered by a hospital. At the start of the pandemic, I was exceptionally clinically vulnerable. It took the NHS 6 weeks to tell me that. That's not safe.
Thank you. Thank you, Chair.
Thank you. Helen Morgan.
Thank you very much, Chair. Can I ask about the single patient record? We've heard concern from GPs about their role in being the data controller and what that might mean when that data is shared beyond their sort of initial remit. What do you think is most desirable? Do you think it's desirable for the GP to remain the data controller, or do you think it's desirable for that role to sit elsewhere?
Do you want me to do first or Kay first?
Dr. Dixon?
Yeah,
Okay. I mean, I'm not a general practitioner. I think data control and data sharing, as I say, is absolutely key. The trust that patients have in us to share and hold their data in a way that is beneficial for them as individuals and potentially sometimes for the population, but not for what you might call retail use. And I think part of the issue about data controlling is most general practices are small businesses with small staff working flat out, and that legal obligation of a data controller looms very, very large for them, whereas it doesn't loom as large, although technically the impact is as hard for large NHS organisations. So I don't mind who controls the data. What we need to do is find a way to enable that data to be shared safely and with a belief that it is done for patient benefit, whether that is the GPs maintaining the data control and something else happening to support them, or whether that's taken that away. I don't think that matters. I think it's about how we enable that to happen. But I do think general practice struggles more with resilience.
Speaking.
I think that's true in that we're generalists, not experts in a lot of areas. Certainly, we can be very good data controllers of our own data. The stuff that we produce, the stuff that we write about our patients, the stuff that we code about our patients. We code things to be able to respond to our contract, so we have to be good at that. When things kind of fall down is when information comes from other providers that we have no control of, and that would be an area of concern, of real concern, that would then be part of our property and our jurisdiction. So I guess it's the detail of how that record will be structured. If it's a brand new thing and we all feed into that, that's very different than all the data coming to the current healthcare record that we hold. So I think the detail isn't there yet to be able to describe who should be that data controller, but certainly I don't think any practice manager would want to control data generated by someone other than themselves.
And can I ask a follow-up question? Is there anything that you think should be on the face of the bill to give that clarity so that that concern for GPs is mitigated?
I think the patients need to understand exactly who has access, exactly who is feeding into that record. There is a huge amount of trust, as you will know, between a patient and a GP, a patient and a healthcare professional in a general practice. And what we don't want is that trust to be diminished. And then the patient stops telling us the things that are worrying them, the whole story. We really want them to continue that trust. And if they think that information is spreading further and further across the system, we might lose some of that.
Surgeon Joseph.
Thank you, Chair. I just want to touch on about the single patient record. I just want to declare that I used to work in the mental health services. And in my own experience, we've seen mental health patients navigate between A&E, GP, mental health services, often during weekends. And often the clinicians doesn't know what medication they're on, what kind of contact they had on a Friday or Saturday. So also during discharge process as well, there's often delay getting medication from the GP until the discharge notification get to the GP. So do you think that, yes, there are certain concerns about who's going to own this data, but there's a huge benefit for patient safety and continuity of care this single patient record is going to bring?
The information, the example you give there, the hospital should be giving 7 days worth of medication for that patient. That's clearly their responsibility. And within those 7 days, the GP practice should get a discharge letter that says what's happened, and then we, if appropriate, take over that prescribing. So if the information comes and it's good quality, so the data's good and it's timely, then those things don't happen. It's when either of those things are not the case. Particularly in my experience, information that comes out of A&E is often difficult to understand. They might make a sort of a diagnosis that they're working with in A&E, and by the time it gets to the ward, that's different. So if we're acting on the A&E information, that might be very different than what the patient is discharged with. So timely information and good quality information is really, really important. And that GP record then becomes the sort of centre of that patient's care.
Dr. Dixon, do you want to add to that?
Yeah, I think you're talking about transfer of care between services, and I think you talk about a weekend as being an important flashpoint, but I think that transfer of care doesn't happen appropriately even during the week. Mm-hmm. I think it's getting better with electronic systems, but it's still not working for the full benefit of patients necessarily, especially if they're accessing multiple services. So I think the single patient record, the value of the single patient record is to make it safe, and to do that, the question is, will it do that? Can it do that? And is it safe to do that? And will the patient's data be protected? And that's what we're worried about. I think that's what patients worry about, that they perceive we do that already, and then when they come against the healthcare service, they realise it doesn't happen, but they don't realise it's not a personal thing to them, it's a systemic problem. And it's about that, getting patients to understand the systemic nature of the lack of data sharing that we do at the moment.
Robertson.
On the single patient record, if management of it and safeguarding and responsibility is to sit with general practice, if that's what the government wants, Kay Keane, Chair of the Institute of General Practice Management, what would be the implication on workload and workforce within practice management? Can you tell us, particularly in relation to workforce, I think?
I think it's impossible, really, for me to understand that. It's a large part of our job already. We, as Dr. Dixon said, we act as a small business. We do all the things that any other small business does. So to then, on top of that, to be able to manage that record would take a huge amount of investment into general practice. And I would argue that maybe the investment into general practice shouldn't be on data. Maybe that should be on the workforce wider than that. That actually we're really good at looking after our data now. We care about it. We hold it close to the care of the patient. We share it only when appropriate. But then to be the data controller of other information, in our view, is too much, and it's unmanageable for a general practice to do. Equally, our data is very personal to us, and we want to keep hold of that. We don't want our patients worrying about the stories that they tell us. So actually, a model where we feed into something else and we have responsibility for that bit that it's fed into sits more comfortably with the Institute of General Practice Management. Thank you.
Dr. Dixon?
Yeah, I think I don't really have much to add to that. I think it's about the devil is in the detail of where it sits and how we reassure patients that we are trusted with their data, that we're sharing what they have given us appropriately for their health, but not for spurious reasons. And as I think people's understanding is that we share an awful lot more than we do, so there is a gap. People perceive that we're going to overshare, whereas actually we're going to bring it up. This will allow us to bring us up to the level we should be.
Serena Brackenridge.
Thank you, Chair. My question is to Dr. Dixon, and it's around education and training policy that will be transferred, the responsibility transferred from NHS England to the Secretary of State. I know that you have much interest in medical training and education, so what do you feel would be the impact?
Dr. Dixon.
I think it could be a really positive impact. I think there is a real at the moment we train nationally, we train to high standards so that the product of medical education can be deployed anywhere in the UK and can also we're all trained to develop, innovate, change the service, move forward. I think the potential is that what we miss at the moment is parity of esteem for education as a productivity function of NHS. There is the productivity function of elective care, of waiting times, of cancer treatment, all those things. Education must sit for all professions at that level of esteem for productivity in order for the service to continue. Not to innovate, to change, to develop, just to continue. And I think by moving things into the Secretaries, we have a chance to have that pure parity seen. The problem is that the danger is that if you move if you move the function in, it gets lost in the service productivity sphere. So I think there is a huge opportunity to firmly embed the education and the strategic development of different roles, a true productivity function of the NHS, which it needs to be.
Hey, Keane, do you wish to add? No?
Nothing to add now.
Do we have any further questions? No? In that case, we've come in under time for a change. Thank you both very much indeed for joining us.
Thank you.
Your contribution is invaluable. Thank you very much.